You know, the culture change movement has been around for almost 30 years, everyone. And to try to touch on something for 4 minutes, of course, it's challenging, but it's just kind of creates an opportunity to look at language. Linda just said to control what we can control. Guess what? Language is one thing we all can change if we want to. Costs no money. And so we've just started there. There's a lot more to culture change. We've been looking at the word patient, and I looked it up, everyone. It's a noun, and it means person receiving or registered to receive medical treatment. Looky there. Here's an example. Many patients in the hospital were more ill than she was. And so, you know, I just heard this a couple times this week, so that's why it's kind of landed here at the beginning. Culture change leaders have been training. We had an online culture change conference in Wyoming. And I heard this again, that the term patient, just like this, is very passive. Things are done unto you. And to be honest, everyone, this is why CMS back in 1987 chose the word resident on purpose, because someone resides there. They wanted to actually move away from the word patient. And somehow I think it's crept back in. I'm not sure why, but we don't have to use it. An ombudsman, Don Runyon from Wyoming, recently said they're a person, not a patient. To be a patient is not a person. It is somebody who has an illness, not as seen as an individual or unique person. That's a leader in our movement, Barry Barkin. And then Mark Marabella might be on the line from your Alaska QIO. I'd love for Mark to teach on this sometime. I have long believed there is a disconnect between people and care. And I think that's what we're getting at, everyone. One time I sat in a session on patient-centered care. I was so excited. I wanted to learn some stuff. And who can guess, after hearing that term, patient-centered care, patient-centered care, patient-centered care, patient-centered care, guess what's missing? I'll take the next slide, please. What's missing is the person. We're all people first. And so I'd love to invite you to think about that, talk about it, catch yourself if you're wanting to do this. So notice, in some cases, we have moved to person-centered care. CMS did with regs in 2016. However, another interesting point is that the culture change movement wasn't saying that anymore. They moved on to resident-directed care. It's even stronger. Someone even living with a dementia can be asked what they want and involved in a directive kind of way. Now, this is kind of funny. I just saw this on a billboard. If we really are talking about care, and sometimes we are, look what I saw on a billboard, youth-centered care. How do you like that? It's kind of like, I've never heard anyone say that. And then if we apply the directed piece, maybe, what if we started using you-directed care? Would anyone like that if you were in the hospital or you were living in a nursing home or one of these settings? I'll take the next slide, please. And then, you know, we keep also mentioning that when we keep focusing on care, we're missing the fact that some people live there and this is their life. And I didn't make that up. It's leaders in our movement that point out, you know, in your real life, your life, everybody, right now, here's your big life, Dr. Bill Thomas says, and you have a little medical care on the side. You move into a nursing home, what's the big part? Medical care. And what's the little part? Your life. And so another way to use language is to talk about life and living more, resident directed life. Star Trek thing this week, you mentioned that, Don. Back one, Barry Barkin mentioned that in Star Trek, if we could go back one slide, please, they talk about a prime directive, right? And what if the prime directive of a nursing home was to always seek to nurture the healthy flow of the human spirit in all our policies and interactions in all we say and do? So forgive me, we came up with the idea, what if we called it a nurturing home instead of a nursing home? And you see there's power in language. It may look funny at first, everyone, but Barry started saying it because when you say nurturing home, that's what we want, even more than a nursing home. And so I'll just skip the last slide. It's kind of a summary of other words we've done. Thank you.
Okay, let's move on to the next slide. So today we are really happy to have Michelle Benson, PharmD, MPH, here to talk about the COVID-19 vaccine and the outpatient treatments. Michelle, take it away.
Yes, can everyone hear me? Awesome. My name is Michelle Benson. I'm very excited to be here today to talk about the COVID-19 vaccine and outpatient treatments. I am a pharmacy resident at North Dakota State University, which is in Fargo, North Dakota, as well as Lake Region Healthcare, a hospital in Fergus Falls, Minnesota. And at the hospital, I have given out a lot of COVID-19 vaccines. We treat a lot of people with COVID in the hospital. And we're also involved in arranging distribution of these outpatient treatments. It's an interesting time to talk about COVID. A couple months ago, the picture was very different. Hospitals always had COVID patients. It was sometimes hard to transfer outpatients, whereas now things have been ramping down. We aren't seeing as many COVID patients. We aren't having to give out as many of these outpatient treatments, but as we have all probably heard, there's a new subvariant on the way, so it's a good time to review things in case they ramp up again. Next slide. So now we have our Slido question, which the link is in the chat if you haven't gotten it yet. Which of the following is true about COVID-19 treatments? You can answer that on your own and continue to answer it as we move on. So our objectives today are our first one, understand the benefits of COVID-19 vaccines. And our second one, become familiar with treatments for people who have COVID who are outside of the hospital. Next slide. Note, super important, the information in this presentation is subject to change as COVID is ever changing. I started making this presentation in March. I have updated it 3 times. Information came out today that is already new and it is wrong again. So it's very important to watch for updates on the status of vaccine recommendations and treatment options from CDC is always a great source, and also our state public. I'm going to start off talking about vaccination. We have our 3 manufacturers here. Start with the one I like the least, Johnson & Johnson. It is our 1-dose vaccine. We know it doesn't work as well as Pfizer or Moderna, our mRNA vaccines. The only thing it has going for it is that it is 1 dose, and you are considered fully vaccinated after 2 weeks of having that 1 dose. They really only recommend it if for some reason it's the only one you have. Not really a thing anymore this far into the pandemic where our supply is much better. Or maybe if you ran into one person who absolutely refused to get more than 1 dose, maybe it's the only choice you have. But if you had someone who had a Johnson & Johnson vaccine who is now open to getting a booster, they do recommend switching to Pfizer or Moderna with your booster. You are not going to get a 2nd dose of Johnson & Johnson ever. Looking at our mRNA vaccines, Pfizer or Moderna, the primary series is 2 doses. 3 weeks apart was for Pfizer, 4 weeks apart. This has been updated. They now say you can stretch this interval out from 3 or 4 up to 8 weeks. And it's thought if you space it out a little bit further, it helps our body build a better immunity by having space in between when we get those doses. We are considered fully vaccinated 2 weeks after the 2nd dose for both Pfizer and Moderna. When we're looking at a Pfizer booster, it's going to be the exact same dose as your primary series, whereas if you're getting a Moderna booster, it is half the dose of the regular vaccine series. And when it comes to mix and match, definitely okay to do it. If you got Moderna for your primary, you can get Pfizer for your booster or vice versa. And it's actually recommended if people are open to it. It's shown that you have a slight boost in immunity if you do mix and match your vaccines. Next slide. So why do we give vaccines? I think this picture says it all right here, looking at COVID-19 deaths by vaccination status. And this is from April of 2021 to January 2022. You can see our unvaccinated population, much higher mortality rate versus those who got vaccinated with at least a primary series. 14 times more likely to die if you are 5 and over and have not had a vaccine compared to those who have. Next slide. We also see this even more drastically in our geriatric population. Our purple lines, those are our patients who are over 80 or persons who are over 80. You can see large differences between those who are vaccinated, those who are unvaccinated, much higher mortality rates. We see it again in those 65 to 79, a little bit less drastic, but still very important to get these people a vaccine. Next slide. And then I mentioned boosters. Why do we give boosters? So you can see there is a much bigger difference in hospitalizations between our unvaccinated versus our vaccinated, the orange and the purple lines, but we know that our vaccines work well, but they do not work forever. So with these boosters, if we want to keep people out of the hospital and getting less sick, boosters are recommended. The bottom blue line being those with a booster, a lower rate of hospitalizations versus those who just had their primary series. And it's not as large of a statistic as mortality, but still hospitalization, still in those over 65, very hard, costs the healthcare system a lot of money, costs persons, a lot of money, and also very hard to be in the hospital with COVID with all the restrictions, not able to see your family. We want to keep people out of the hospital as much as possible. So recommending those boosters for everyone, but especially in those over 65. Next slide. Common questions that come up about the COVID vaccine. First question that often comes up, which is a very important question and reasonable to ask, are they safe? And because these vaccines were very fast-tracked, because every company who makes vaccines was putting all of their time and money into them, and the FDA didn't review them in a different way, they just bumped them to the top of the line, but the same trials were done to see if they were safe. And we know there are some slight side effects, but overall, millions of people have had this vaccine by now, and we know they work really well, so they are safe overall. But nothing is out without risk, so you can never say something is 100% safe, but in almost everyone, they are very safe. That doesn't mean people don't have slight reactions to the vaccine. It's fairly common, more often after the second dose versus the first dose, to have a small reaction. It's typically a virus-like symptoms, feeling chills, achy, maybe a slight fever, and it really only lasts a day or two at most. So super short term, although it's another reminder, we want people to feel well when they're getting vaccines. Don't give sick people vaccines. It could make them feel even worse. But you can also take Tylenol, ibuprofen after having a vaccine and having these symptoms. We don't want to take these before getting our vaccines just because they think that can interfere with our body creating antibodies. But if you are having symptoms after, you can definitely take some Tylenol or ibuprofen. Now we talked about boosters, and boosters are different than third doses. Third doses are for our immunocompromised patients. And so there's a specific set of patients outlined by the CDC who qualify for third doses, and that would be as part of their primary series. So there are people who have had their first, second, and third dose and then got a booster. So there are people who have received 4 doses at this point, but third doses are not recommended unless you meet these certain criteria. And then people ask, are we going to have to keep getting them? Which it seems like it. The CDC just recommended a second booster today for those people who are over 50 or 50 with immunocompromised conditions, or anyone over 65, at least 4 months after you had your original booster. The thought is to try to figure out how often we have to keep getting them. We know they don't last forever, but eventually it will probably move to a more set timeline of how often we have to get them, but it's pretty unlikely we are done getting them in our lifetime. Coverage versus different variants. We know with the Omicron variant, it didn't work as well as some previous variants. When our viruses mutate, because of how vaccines are designed, they might work a little less well against them. That isn't to say that they don't work at all. So still important to get those vaccines, even if they are working a little bit less well. And then another question, how long do I have to wait after I have had COVID to get vaccinated? This has changed. There used to be about a 3-month interval. They recommended you wait. Now, as soon as you are symptom-free, you can get that vaccine. And this might be a good time to prompt people because after they've had COVID, they might not want to get it again. So as soon as they are symptom-free, they can get a vaccine or a booster. Next slide. We're talking about the COVID vaccine. There are a lot of people who have not gotten the COVID vaccine. About 80% of people in the US have had at least 1 dose. That means there's about 20% of people, or 1/5, who have not had a single dose. And not getting a vaccine, a lot of people have reasons why they don't get vaccines, very reasonable reasons. A lot of wonderful people have not had vaccines. A lot of wonderful healthcare providers choose not to get the vaccine. It doesn't make a judgment of whether you're a good person, whether you care about protecting people. People make their own decisions. But if we are going to be recommending this vaccines, you want to have information available, especially from reputable resources. If people are want to learn more about the vaccine, we never want to get into politics when talking about the COVID vaccine. We are approaching this as healthcare providers and trying to stay away from that and getting into those types of arguments. If you are looking to up vaccine rates in your community, it's always smart to try to ally with community influencers who are outside of healthcare, people who work in schools, community centers, the police if they're trusted in that area, to try to talk to people outside of healthcare and why they should get the vaccine. Want to always be respectful. These can be difficult conversations to have. A lot of people have opinions, but at the end of the day, we're all people, want to treat them with respect and be prepared to play the long game. Although that's not to say if someone is super against the vaccine, you bring it up every day, but it is okay if someone said no once to ask them later if they've changed their mind or if they're open to talking about it. Next slide. Now we're going to shift to talking about our outpatient treatments for those with COVID. So someone who has COVID, but they are not sick enough to be in the hospital. We have 4 treatments right now, and they are ranked in order of preference. We have Paxlovid, Remdesivir, Bebtelovimab, and Molnupiravir. And the other ones on the right side of the slide, Evusheld is specifically for people with immunocompromised conditions. They can get this monoclonal antibody from specific sites that have it, and this is more of a prophylaxis to prevent them from getting COVID or getting less sick if they do get COVID, but only specific sites would have that. And we also had other mAbs in the beginning that no longer work because of our variant shifts. So just if those ever come up, maybe they'll come back. You've seen them before. Next slide. Our first drug is Paxlovid, and it is our first choice option if we can get it. It does need to be started within 5 days of symptoms. So if you have someone who's displaying symptoms, the sooner they get tested, the sooner they could maybe get Paxlovid. It is 3 pills in the morning and 3 pills at night. So 6 pills a day for 5 days. So a fairly high pill burden for those who aren't swallowing well. It's actually a combination drug of antivirals, nirmatrelvir and ritonavir, and you're going to be taking that for 5 days. In clinical trials, it reduced the risk of hospitalization or death by 88%. We know it has been effective against Omicron, something specific to Paxlovid. It has significant and complex drug-drug interactions. So anyone who's getting Paxlovid, you're going to have to screen all their medications they take by a pharmacist to see if there's anything we need to do to manage those drug interactions. And that doesn't mean just because there is a drug interaction, we can't give Paxlovid. You can hold medications or reduce doses for a couple days, but it is something you have to adjust. Paxlovid also has different doses if you have poor renal function. So that is something you need to know about a person before prescribing it. And as I mentioned, it is a fairly high pill burden while we're on Paxlovid. Next slide. Then we have Remdesivir, which is an antiviral. You've probably heard of it being given inpatient, which it is in the hospital for people who have COVID, but now we are starting to give it outpatient as well. It needs to be started within 7 days of symptoms, so you have a slightly longer period. The thing that's less great about Remdesivir is it needs to be given for 3 days, and it's an IV infusion. So there are a lot more logistical considerations versus just these one-time treatments. It's 200 milligrams on day 1 and then 100 milligrams on days 2 and 3. This 3-day course was shown to reduce the risk of hospitalization or death by 87%. But in order to give Remdesivir, you need to be in a setting where any severe reactions can be managed. It's rare to have a severe reaction, but we always have to be better safe than sorry. And you still have to be monitored for 1 hour after an infusion. Next slide. Then we have our monoclonal antibody, bebtelovimab. Want to start this one again within 7 days of symptoms. And it is only recommended if none of the other preferred therapies are available, feasible, or clinically appropriate. It is a single IV infusion, but the data for bebtelovimab mostly comes from in vitro studies, so studies that were done in labs rather than in our human patients. So it doesn't have as strong of data as other treatments, and you're still going to have to want to do it in a setting where hypersensitivity reactions can be managed and watch our patients for an hour. Next slide. Our last option is molnupiravir. We can see it's the umbrella because it's really the only option we have if nothing else is available. Again, it has to be started within 5 days of symptoms. It is 4 pills twice a day for 5 days. So again, a high pill burden, and it only reduced the risk of hospitalization or death by 30% in clinical trials. We know it works a lot less well than these other treatments, but at the end of the day, it is better than nothing. So if your only option is molnupiravir, it is an okay option. Next slide. So summary of what we've talked about so far. Want to recommend all of our residents and staff get their primary COVID-19 vaccine series and booster. Mix and match strategies for COVID-19 vaccines are recommended. If you get one manufacturer, you can get a different one for your boosters. Want to deal with vaccine skepticism with patience and compassion. There are antiviral and mAb treatments available for people who are outside of the hospital to prevent them from getting to the point where they need to be in the hospital. Although each of these treatments comes with their own pros and cons, and treatment availability varies very widely by location and demand. So the best people to ask would be in your area pharmacies, hospitals. They would know much better than I would what is available where you are. Next slide. And then something we wanted to bring up was talking about long COVID and the brain, just because this was in the news recently and a lot of questions are being asked about it. It is fairly common after having COVID to have physical or psychological symptoms that last for even a couple months or longer. And there have been evidence of brain abnormalities in people who have had COVID. There's a study that came out of the UK, although it was preprint, so not as reviewed. And they looked at people's brains who had COVID, people's brains who did not have COVID, and they saw differences in the gray matter, which is where our brain processes information, as well as changes in our brains dealing with smell and taste, which kind of makes sense with how the symptoms of people who have COVID lose their sense of smell or taste. A very tiny reduction in global brain size, so not something to be very scared of. And there was some differences in cognitive decline. And people often describe brain fog after having COVID. They just don't think as well as they used to. They can't grasp onto words like they want to. So it is something that happens. But the reason we don't talk about it as much is you are still going to be referred and treated as if you had these symptoms for any other reason. There are no specific treatments for COVID-19 brain fog. You're going to get referred on to a neurologist and worked up like any other patient. Next slide. So now we're going to get into a patient case. So patient at your facility has been feeling slightly off for the past 5 days, but has just brought up their symptoms to staff today. They take a rapid test, positive for COVID-19. Our patient is a 70-year-old female who was vaccinated, and asking what treatment options are available for them as an outpatient and which would be the best choice if they, and kind of separated it out into 4 different scenarios. So for our first scenario, if this patient had a complicated drug regimen with lots of drug interactions, and anyone can answer what would be the best choice for them. Yep, I'm seeing someone saying a mAb. A mAb would be a good choice. And this specific patient before we went to MAB, because none of our MABs work that well anymore, we would try to get remdesivir before we did a MAB, but since that's not super feasible, a MAB would also be an option. And then looking at patients who aren't able to get infusions, what would be our best treatment options for those patients? Yes, oral drugs such as Paxlovid, and then there's no other option, molnupiravir. With people who had symptoms over 5 days, there's 2 options for that. Yep, remdesivir would be one. Ask the pharmacist. Yep, that's always a good choice too. They will let you know. And then I think we've gone over, if there's no MAB availability, we have Paxlovid and molnupiravir. So we can go to our next slide. So ending on a positive note while talking about COVID, a couple years ago, we didn't have anything. We now have highly effective vaccines and treatment options that we did not have. And though I made this a long time ago, when our COVID-19 numbers were more downtrending, it's still much better than it was a while ago, but some
These under emergency authorized use meds with appropriate customer informed consent.
Yes, as far as I know, none of them have been FDA approved and they're still under EUAs right now. So, and the correct answer does have the most answers: Paxlovid, extensive drug interactions, and dosing adjustments. So good job, everyone. Oh, and I wanted to mention, even though the treatments are under EUAs right now, all of our vaccines are FDA approved, but the outpatient treatment.
So thanks. I haven't ever been with this group before, so I'm really happy to be here. I work with Crystal, I believe you've heard from. I don't know about Jill Holt and Marcy Gallagher, but I work with them with Mountain Pacific. I am based out of Anchorage, Alaska. And I support nursing homes in Alaska and Hawaii. And prior to joining Mountain Pacific about a year ago, I was a quality director for a couple of homes here in Anchorage. Last week, you were asked to write a SMART statement, I believe, by Crystal. So what we would like to do, so you can see what other folks are doing, is to share it in the chat and the feedback that you got from that SMART statement. All right, so it'll be great to see those pop up. So next slide, please. So I believe, as I was starting to say, that step 5, the creation of the QAPI plan, is part of the element 1, which is the design and scope of your QAPI efforts. So the goal is you want to create a structure and a plan that's going to support your QAPI efforts. I believe you already covered your purpose, your guiding principles, and your scope. So now this is your plan, and I've linked it there. That the expectation is that this is going to be a living document that you're going to continue to revisit and refine. It must be updated or reviewed at least annually, but I would say that if you've got some changes that you've seen come across over the course of a year, say, for some reason your patient population has changed dramatically, resident population has changed dramatically, or you've taken on a new service line or something like that, you would want to review it upon a significant change like that. Next slide, please. So I'm just going to review some of the QAPI plan basics. The first is you need to address your resident population, the issues that you're seeing within your home, and determine what sort of goals do you want to address with your council. We talked about setting SMART goals. The thing I really want to hit on is that you're going to tailor your plan to the residents that you have in your building, the units that you have, and programs that you have. So for example, if you have a significantly younger population, your plan might be tailored to the needs of that population. If you have a high population of rehabilitation and short stay folks, you're going to tailor your plan specific to that. I will say that, larger corporations might have an overarching plan, but they're going to have to allow for the flexibility of the individual homes to address their own needs. Like I said before, and the surveyors will look to distinguish that. So always be thinking of identifying and refining your goals. Next slide, please. So your plan incorporates guidelines for governance and leadership. The biggie is, how are you going to integrate your QAPI efforts into the responsibilities of really everybody in the house. So it's important to make sure that upper senior leaders in the board of directors are involved, and you describe how that's going to happen. How are you going to ensure your resources, and what's going to be the structure of your QAPI process? So who's going to be in charge of pulling everybody together? How are you going to train leaders and staff? How are you going to determine if your resources are adequate? And how are you going to ensure, say, the competence of your caregivers? Do they have the tools and the know-how they need to participate on PIPs or to identify quality issues? Next slide, please. Then you're going to need to incorporate your systems for monitoring. What are your data sources going to be? How are you going to collect it? How are you going to analyze it? And how are you going to let people know of your findings and whether or not you've made improvement, and help them to understand when you're communicating your data, what it means when they see that pop up either on dashboards or reports. Who are you going to give the information to? How frequently? What's that going to look like? So some of your data sources are going to include input from your caregivers, residents, families. You should be monitoring your adverse event logs, performance indicators. You can use your CMS survey findings and CASPA reports, complaints, benchmarks. You get data from all kinds of sources. And then it's important to share it across your organization, including residents and families. Next slide. So then you need to describe your plan for your PIPs, or your performance improvement projects. So you've got to understand how you're going to identify them, how you're going to prioritize them. I think this is really important because we tend to want to boil the ocean. We want to do it all. If we see an issue, we want to jump on it right away. But if you take on too much, you're not going to succeed at any of them. So how are you going to prioritize what's important? Oftentimes it's high frequency, high risk areas. How are you going to develop your charters? How are you going to report out your results of your PIPs? And then how will you find the folks to be on your teams? Think about what are the required participants and characteristics for your teams. Who do you need to be at the table? That's really critical. And how are they going to report their work out? And then your overall documentation of the PIP. I know that there's some software out there. We used Abacus in my home. I'm not plugging that. I don't have any link to Abacus, but they had, and I'm sure there are other softwares out there that allowed you to develop your plan within that software and also to document your PIPs. So you would give people access to the documentation for your meeting minutes and your progress and communications, and that can be really handy. Next slide. So then think about your effects. Analyze, the systems and the actions that you're taking and how it affects your entire organization. Oftentimes we don't realize some of the consequences either, prior to that process or after that process, upstream or downstream, what effects might be on other areas. And you have to have a process in place to be able to identify and address those. Ideally, you've thought a little bit about that and may have some of those people who participate in those processes on your team. But if not, bring them in and help identify and address those consequences. Ensure that when you've got some information for a PIP, you're addressing root causes of the concerns that have been brought up and not just putting Band-Aids on the symptoms. Otherwise, it's just gonna, if you don't address that root cause, as it's gonna continue to be a problem for you. How are you gonna monitor to make sure that your PIP has been successful and that you've had sustainability and you're able now to increase some bandwidth for another project, but how are you going to keep an eye on what you just addressed? And then the measures, determining what measures you're going to use to monitor your progress. So here's a few different types of measures. A structural measure is focused on fixed characteristics of an organization. I don't know that I've used structural measures that frequently. An example would be, and I think this might be kind of an outdated example, but the extent to which you've got electronic medical records being used in your home. For example, the number of departments using the same EMR. I can say that the home that I came from had providers documenting in Epic, nurses and CNAs documenting in another, it was called ECS. There were still some things on paper. So if we were to address a structural systemic measure, one might be, how can we get people onto the same, and at what rate are we getting people onto the same hardware and software? A process measure is you're measuring the steps in a process. So did you follow all the steps in that process correctly? One example might be that folks who receive insulin have 2 nurses check prior to administration. That's a basic process measure. Outcome measures, we do focus a lot on these. Obviously, the QMs, CMS's QMs are mostly outcome measures. And unfortunately, you're now measuring it after the fact. So that's why we like to incorporate some of these other measures. And it's a result of a performance or a function or a process. So an example of that might be that you want all of your folks with diabetes to have an A1C that's less than 7%. So the outcome of the medication process is folks whose diabetes is well controlled, or say non-medication interventions, is that you're controlling that diabetes. And then a balance measure also isn't super common, but this is one, at least I haven't used it extensively. I'd certainly be interested to hear if other folks have. It is a measure you might use to identify unexpected consequences. So for example, you could decrease falls by restraining everybody, which obviously is not a good idea. So if you are looking at falls, a balance measure might be to look at restraint use, for example. Next slide, please. And then sort of for everything, you need a communication plan. And I've touched on this before. Who's going to receive the communications? What will the frequency and format be? And then how are you going to evaluate your program on a regular basis? CMS provides a tool for that. I've tried using that a couple of different ways. We would do it either in meetings, or I would send it out and then kind of collate people's responses, and we could certainly see our growth. And then describe, so what are you going to, now you've assessed your program, what are you going to do about that? How are you going to expand your skills and increase your impact? Next slide. And then you, easy as pie, right? You just establish your plan and make sure it's dated. Determine, like I said before, when you're going to revisit it, how you're going to track your revisions or updates, and then so critical to celebrate your wins. It's hard to keep everybody on board. I always, it was hard for me when I first started at these homes, there was sort of a mentality of, well, your quality, you take care of everything. And we all know that's not the case, that you're sort of the gatekeeper perhaps, but quality is everybody's responsibility. And celebrating and making sure that they understand the impact they're having is critical. Or I would use as the outcome measure, your new pressure ulcers would be a task. And I highly recommend you go back, assess the composition of your QAPI team, your council, and have a conversation of, is everybody that you need to be at the table? And this is going to be different for everybody. As I said earlier, depending on the people that you're serving and the type of home that you have. Consider if you've got CNAs, resident families, those, in my experience, have been really hard to get to the table. Our residents, family, and CNAs, because, and even now they're so scarce, it's hard to get them away from what they're doing during the day to come to meetings. But they can have really, really valuable insights. we did years ago had a alarm PIP, and our CNA group lead was instrumental in figuring out why we were putting so many alarms on people. Nobody really seemed to know the answer. It was just sort of how it was done. So CNAs, yeah, can be so critical. Resident families, EVS, dietary, depending on what you're looking at, just take a look at those teams and make sure you've got everybody there. Okay, here's a fall PIP. The SMART goal was to decrease, the fall quality measure percentile to less than 75 through identification of high fall times and locations and implementing interventions to decrease falls by 8/1/22.